Good afternoon, everyone. It's my pleasure today to introduce Dr. Rami Komrokji, who will be talking to us today about his research in myelodysplastic syndromes. Rami is actually clinical director of hematologic malignancy in the Department of Hematologic Malignancy at Moffitt, and he's the lead clinical investigator for myelodysplastic syndromes over there. Rami graduated from my school, University of Jordan, in 1995, and he has been somebody that I always looked for as a role model for me. He actually also went to Rochester, where I did my residency training, but we never overlapped. And subsequently, when I worked with Steve on MDS, our roads came to a meeting, and we started doing some work together. We had multiple projects together. Rami has done a lot of work in the area both of MDS and MPN, and today he will be presenting some of the latest updates on MDS for us. Thank you.
Good afternoon. Thank you, Amr, for the great introduction. It's always an advantage that somebody can pronounce your name finally. So I really had pleasure working with the group here. I think we've had several projects with Amr and Thomas, and Dr. Gore had been, in a way, a mentor for me, advised me through my career. I remember the first ASH meeting, he was like sitting next to my mentor, and I was presenting, and he's, "Who's this guy?" I could see him saying that, and then he stands up, and when Dr. Gore stands up at ASH, you just hope that he's going to be nice to you. And he actually was very nice to me all through my career, so thank you. So I'm going to provide overview on myelodysplastic syndrome, focusing a little bit on what we've been doing, so maybe it's a biased view a little bit. So as you know, myelodysplastic syndrome are spectrum of disease. Clinically, they are characterized by bone marrow failure, ineffective hematopoiesis. The hallmark is macrocytic anemia, but any cytopenia could be a presentation for MDS. Nowadays, we know that in majority of the patients, actually, we can identify clonal hematopoiesis in those patients, whether it's by regular cytogenetics or by the introduction of newer techniques like next-generation sequencing. And the hallmark pathologically is the presence of the dysplasia, which is a misnomer. It's basically a morphologic description of how the cells look under the microscope, not the definition of a precancerous condition. And this could be tricky, obviously. It depends on the hematopathologist experience. And finally, it has a tendency to progress to acute myeloid leukemia. So if you take all MDS patients, around probably 30–40% of the patients will end developing acute myeloid leukemia. However, unfortunately, 60–70% of the patients will still die from complications related to the disease. So to make diagnosis for MDS, the entry criteria usually is presence of cytopenia. So the suspicion usually arises when there is cytopenia. And one has to demonstrate one of the three following criteria. Dysplastic cells, so a good hematopathologist will count 200 cells in each cell line, and if 10% or more of any cell line looks dysplastic or abnormal under the microscope, then that could be called MDS. Or if the myeloblasts are increased, or nowadays if there is a certain karyotype in setting of cytopenia, one can make a presumptive diagnosis of MDS. So if somebody comes with anemia and they have deletion 5q, there is no other explanation, then that can be called MDS. So obviously, there is some variation in the experience in calling MDS. There is a paper from MD Anderson, and we had the same experience that in almost 20% of the cases we see, we change the diagnosis. So I've seen patients that had MDS for several years, never called MDS. I've seen, unfortunately, patients treated with azacitidine for a year or two, and their bone marrow was only showing iron deficiency anemia. So it really requires a specialized center and some hematopathology experience to call the diagnosis of MDS. So nowadays, I think we know that genetic events or acquired somatic mutations are common events in MDS. So in majority of the patients with MDS, we could show a clonal hematopoiesis evidence. So in the past, we used cytogenetics with the classical G banding or karyotyping, and maybe by the FISH technique as well. And we could identify abnormalities in 30–40% of the patients with MDS. Nowadays, with the introduction of the sequencing techniques, we could probably identify at least one abnormality in almost 90% of the patients with MDS. And if you look at those abnormalities, you probably can lump them in certain pathways. The most common pathways involved in MDS are epigenetic deregulations, mutations in genes like TET2, IDH1, 2, DNMT3A1, and surprisingly mutations in the splicing machinery. So for example, mutation in a gene called SF3B1 is commonly associated with a subtype of MDS called refractory anemia with ring sideroblast. SRSF2 tends to happen more in MDS MPN like CMML. So the other thing we learned over the last few years is that there is really a spectrum of this clonal hematopoiesis. So there were two New England papers looking at acquired clonal hematopoiesis by aging. So those were studies, I think, for diabetes or heart disease, where they sequenced patients. Those patients did not have any cytopenias. And above age of 60 or 70, you start seeing 10 to 20% of the population will have evidence of clonal hematopoiesis by at least presence of one acquired somatic gene mutation in the hematopoietic stem cells or hematopoietic compartment. And those genes tend to be common ones that like we see in MDS as well, like the TET2, ASL1, DNMT3A as well. But if you look at those mutations or the size of the clone, typically those are not the dominant part of the hematopoiesis. So like around 10 to 20% of the hematopoiesis is clonal, the rest is not. So it's unusual to see aging-related clonal hematopoiesis as the dominant clone. And what we learned that this is actually not a benign phenomenon, that those patients are at much higher risk of developing heme malignancies, not specifically MDS, but also lymphomas, myelomas. And their mortality is much increased than patients that don't have clonal hematopoiesis. We had a project in our lab to have controls for the sequencing, so I volunteered. So I know as now I don't have any clonal hematopoiesis. And now that also extends to an entity we used to call ICUS, idiopathic cytopenia of unknown significance. So we have those patients that are cytopenic, but we could not demonstrate the findings on the bone marrow that are diagnostic for MDS. We exclude all nutritional deficiencies, all other things. We call them ICUS, like basically MGUS, like MBUS. And what we learned recently that a group of those patients, almost 1/3 of them, will have also evidence of clonal hematopoiesis, whether it's by regular cytogenetics or by next generation sequencing. You can identify a mutation in almost 1/3 of those patients. And again, they tend to be mutations similar to what we see in myelodysplastic syndrome. So now we look at a spectrum of those diseases. So you have what we call CHIP, clonal hematopoiesis of indeterminate prognosis or significance. So those patients do not have cytopenia, no bone marrow findings, but they have mutations. You have this idiopathic cytopenia of unknown significance. Some of them have clonal event, which tend to have more tendency to progress to myelodysplastic syndrome. And then you have the spectrum of myelodysplastic syndrome. So you could think of it how we think of MGUS or MBUS. Now we have CHIP as well. And you could look at a rate of almost like 1% of those progressing. Many of those will not progress. But the progression is not necessarily always to myelodysplastic syndrome, but it could actually be other myeloid neoplasms or lymphoid neoplasms as well. So once usually we establish the diagnosis for MDS, the next step is staging or risk stratification, which I think is a common theme we do in any of the diseases we work with. And the idea there is to provide some prognostic information for the patient, but also tailor our therapy. And in MDS, as we will discuss, we probably have limited options. Our only curative option is allogeneic stem cell transplant. So we are always trying to gauge the risk of the disease against the risk of the procedure itself. So for many years, we used a staging system called IPSS, International Prognostic Scoring System, where we weigh on the percentage of myeloblasts in the bone marrow, the chromosome makeup of the cells, and the lines of cytopenia. And we lump up the score for the patients, and we divide them into 4 stages. Hematologists like to call things low, intermediate, rather than stage 1, 2, 3, 4. But a high-risk MDS have a median survival probably less than 6 months, which again, if you think of it in terms of solid tumors, this is probably worse than many of the metastatic solid tumors we deal with. While somebody with low risk, it still impacts their survival, but their survival is measured in several years. And we use this system since probably 1997. It's probably a good entry point. It gives you a rough idea about the patient risk, but it's clearly not predictive for the outcome for all the patients. So there had been attempts to kind of refine that. So for example, the depth of the cytopenia was not accounted on the IPSS. So if a patient had platelets of 90 or 10, they are treated equally in the system. And we know all clinically somebody whose platelets are 10 are not going to do as well as somebody whose platelets are 90. And the cytogenetic risk groups were really very simplified. So the revised IPSS, which is now incorporated in the guidelines, try to address those shortcomings. And it seems to be better in predicting outcome than the IPSS. Now patients are divided into 5 risk groups where you could predict their outcome and their chances of progression to AML. This is our own data. Like, we were one of the first groups to look at the validation in context of treated patients, and we saw exactly similar to the original publication that we could distinguish the outcome based on 5 groups very nicely. Now, we took this in the MDS consortium, which is like 5 or 6 centers that pool their data together, and Amr actually took the lead on looking at this project. We tried to look at, there had been several new risk models proposed in lower risk MDS, and the idea is to identify those patients that have a little bit higher risk disease than what we call typically lower risk. And he looked at models like a model proposed by MD Anderson, or the revised MD Anderson model, or the revised IPSS, sorry. And he clearly demonstrated that new models are better than the original models. However, even with the new models, if what we call lower risk MDS patients, and we most of the time we not tell them that they have even a heme malignancy, 25% of those patients have a survival less than 2 years. And even with the new models, it only captures almost half of those patients. Now, what is the reason for the death in those patients? Some of it is related to the cytopenias as disease complications, but also it could be age-related because many of those patients are in their 70s and 80s as well. But even with the newer risk models, we are missing almost half of the patients. But the bottom line, the newer models are a little bit better. You probably upstage somewhere between 15 to 20% of the patients, where you could really have better estimate of their disease risk based on the newer models. This is again some work we did with Amr, looking at all those risk models in the higher risk MDS for patients treated with Azanucleosides, which is probably the only treatment we have in MDS other than transplant that shows a survival advantage. And he nicely showed that, you know, any of those models predict the outcome for the patients, where patients that are labeled lower risk by those models have better outcome. And they probably, all the new models do better than the IPSS. But none of those models were predictive of response to therapy. So you could not say, oh, this patient is a low risk by revised IPSS, so he has higher chance of response. They predict outcome, they predict survival, but they don't predict response to therapy. And the other thing that's demonstrated, that probably the outcomes in real life for the general cohort is not as probably as high as mentioned in the original study. So the azacitidine original studies demonstrated almost around 24-month average survival, but most of those real-life databases had demonstrated somewhere between 15 to 19-month average survival for patients with higher risk. And then we also looked again on patients that have therapy-rated MDS. So the classical teaching is therapy-rated MDS usually carries worse outcome, poor prognosis. And most of the time that's the case, because 70 to 80% of the patients with therapy-rated MDS have poor cytogenetics, you know, increased blast. And we tried to look and compare the therapy-rated MDS with de novo MDS. And stage by stage, if you look by any model, a therapy-rated MDS don't do as well as de novo MDS. However, there are a group of patients, even what we call therapy-rated MDS, although they are not the majority, that have a median survival estimated in several years. So in the past, we used to think of every therapy-rated MDS that's automatic transplant, this is a higher risk. And in reality, if you apply those risk models, you could identify a small group that it's probably reasonable to go stepwise treating those patients rather than moving immediately to transplanting those patients. And now, obviously, in the prognostic models, we try to incorporate the molecular data. This is a paper from Rafael Behar in New England as well, that he showed that presence of any of those gene mutations adds to the prognostic value of the clinical model. So if somebody have an intermediate 1 risk and they have a p53 mutation, they automatically have an outcome similar to intermediate 2. So it upstages the patients by 1 stage if they have one of those mutations. And this year, in a collective effort from several centers, they tried to look at several genes in a large cohort of patients, and they showed that the only favorable mutation in MDS is presence of S3B1 mutation, which is a splicing machinery mutation that commonly is associated with refractory anemia with ring sideroblast. And like cytogenetics, obviously, the number of mutations matter. So those patients that have several mutations will not do as well. And we tried to look into also multivariable analysis, and we demonstrated that those patients that have mutations such as P53, RUNX1, have worse outcome independent of the revised IPSS. And again, the only favorable mutation is presence of the SF3B1. Now, when we look at the P53 mutation, I think we learned in MDS, like other diseases, that presence of P53 is typically a bad, a mutation. And if you look at patients that have complex karyotype, which usually have worse outcome in MDS, almost 40 to 50% of those patients will have a P53 mutation. It happens to be enriched also in patients that have monosomy 5 or deletion 5 abnormality. So if you take those patients that have complex karyotype and look at them that they have wild type P53 versus mutated, the wild type actually behaves almost like close to a normal karyotype. So the driver of the bad, outcome in patients with complex karyotype is often the presence of P53 mutation in those patients. The mutations, I think our approach originally for those mutations had been simplistic, like we call them positive, negative, but the reality, I think it's more complicated. First, even calling a mutation is not an easy task because not all the mutations are equal. Some of the mutations are functional, some of them are not. But also, I think there's impact of the size of the mutation or the clone that's mutated. So we tried to look in our cohort at patients that have P53 mutation, and those patients obviously that had wild type had better outcome. But then we asked the question, does the allele burden or the frequency of the mutation detected makes a difference? So those patients that have what we call variant allele frequency more than 40% really had worse outcome, while the patient had smaller clones had better outcome. So probably it's not just matter of presence of the mutation, but how dominant is that mutation or how dominant is that clone contributing to the hematopoiesis. So moving to treatment, like when we talk about lower risk, so most of the patients actually, or 2/3 of them are classified as lower risk. As I mentioned, if we use some of the new risk models, we probably can upstage some of those patients. In lower risk patients, the risk of probably pursuing allogeneic stem cell transplant upfront is more than the risk of the disease. So we typically go stepwise, and the goal of therapy most of the time is to alleviate the cytopenias for patients and the related complications. And currently, the options we have are best supportive care, erythroid stimulating agents, lenalidomide, hypomethylating agents, and immunosuppressive therapy. So this is kind of an algorithm that we follow. Usually, most of the patients with lower risk, we are treating for anemia. So if they have a good chance to respond to erythroid stimulating agents by not being heavily transfusion dependent or have low serum endogenous EPO, we start with erythroid stimulating agents. If there is no response or they don't have low chance of response, then we move forward. Patients that have deletion 5q, lenalidomide is probably considered the standard of care for those patients. Patients that don't have deletion 5q, we try to select between 3 options: immunosuppressive therapy, lenalidomide, and hypomethylating agents, which I'll talk a little bit about how we make that choice. So lenalidomide for MDS, as you know, it's approved by the FDA for patients that are transfusion dependent, lower risk MDS that have deletion 5q. In that subset of patients, almost 70% of the patients become transfusion independent. The median hemoglobin increase in those patients is almost 5 grams with a duration of response of 2 to 3 years. And most of the responses are achieved early on. You see them within 3 to 4 months. In the non-deletion 5q, which is majority of the patients, the responses are less. They are in the range of 20 to 30%, and the duration of response is less for those patients. This is some work from our group that we tried to look at the mechanism of action for those medications and why deletion 5q patients are more sensitive. So it turns out in deletion 5q there is a loss of a gene or haploinsufficiency of a gene called RSP14, which is a ribosomal gene. Its loss leads to upregulation or increase in the erythroid P53 overexpression that probably leads to the apoptosis or erythroid hypoplasia that we see in this subtype. And when we look at those patients when they are treated with lenalidomide, at time of response, their erythroid P53 goes down, and at time of resistance, it comes up. And it seems that the mechanism of action is indirectly through another protein called PP2A. So based on that, we tried to look at strategies where we can, improve the outcome in patients that have, resistance, whether it's primary or secondary to lenalidomide. So the first thing we attempted was addition of dexamethasone, because as you know, dexamethasone can suppress P53, and we did a small cohort of patients where we did 20 milligrams weekly in addition to lenalidomide. So out of 8 patients, in 5 of them, we were actually able to gain some erythroid responses for a duration variable from, less than 6 months to somewhere around a year and a half. Interestingly, none of those patients you see any change in their cytogenetics, which is probably speaking for the mechanism of action that you are downregulating the p53 in those patients. But most of those responses are short-lived, and eventually the response is lost again. But that's a simple trick in some patients that have Len failure in deletion 5q that one could gain at least temporarily the response back. And now we are trying to look into the same pathway to introduce some newer drugs. We've been testing a drug called Senersin, which is an anti-p53 oligonucleotide. So far, I'm not impressed much with the activity. And we're introducing another drug that is direct pp2-1 inhibitor, which part of the lenalidomide action is through inhibition of pp2-1. So those 2 trials we have currently are for patients that have deletion 5q after lenalidomide failure. In the non-deletion 5q, as I mentioned, the responses are less than what's reported with the deletion 5q. So almost around 20 to 30% of the patients will become transfusion independent. We typically use lenalidomide in lower risk non-deletion 5q if they are only anemic, purely anemia. It really does not work if they have thrombocytopenia or neutropenia. In attempts to try to improve on the current standard, we did this study a few years ago where we tried to add ESAs to lenalidomide. So we took patients that had no response to erythroid stimulating agents, and they had no response to monotherapy lenalidomide, and we combined them together. And in that combination, we saw around 20% responses after being resistant to monotherapy for both agents. And this had actually gone further into 2 randomized clinical trials, one done by the French group and completed, and one is through the intergroup study that's still ongoing at this point. And the French study suggested that the responses were higher with the combination, and the transfusion independency was higher, although it was not statistically significant. So this is one approach, maybe trying to improve the outcome in the non-deletion 5q for those patients. Now, we also tried to look at the sequence of those agents, because at one point, hypomethylating agents were started to be the standard. Patients stop responding to ESA. Everybody goes to hypomethylating agents. I think anecdotally, everybody started to observe that those patients don't do very well after AZA failure. When lenalidomide was approved or tested in clinical trials, patients were not treated with AZA. So we tried to look at this project, and again, Amr took the lead and published this. So we asked the question, does the response matter if you use lenalidomide first or not? So in patients that had first-line lenalidomide before AZA, responses were around 38%, while if we used it as second line after AZA, the responses dropped down to 12%. There were no differences in response to AZA, whether it was done first line or second line. So basically, in patients that are purely anemic after ESA failure, it's probably reasonable to consider lenalidomide first and then hypomethylating agents, not the other way. But again, this is a small cohort, obviously, of patients. Now, this is some work also we've done together with Thomas, trying to look at outcome of patients after lenalidomide failure. We looked at 2 cohorts, the patients that have deletion 5q and the patients that don't have deletion 5q, and he presented this data last year at the American Society of Hematology meeting. So basically, in patients with deletion 5q, the outcome after failure is really not as good as we think, with a median survival of 30 months. And in the patients that don't have deletion 5q, around 40-month survival after lenalidomide failure. Interestingly, we see similar responses in real-life experience to what's been reported in the clinical trials. The best outcome for those patients was if they underwent allogeneic stem cell transplant, if they had investigational therapy or hypomethylating agents after failure of lenalidomide therapy. So as I mentioned, azacitidine is commonly used in community practice and in practice for lower risk. The data suggesting survival had been established in higher risk, but we use it in lower risk, only in the United States actually. In Canada and Europe, it's not approved and not used for lower risk. And in lower risk patients, we use a regimen we call the 5-day regimen, so it's only Monday to Friday schedule, based on this study from Dr. Lyons, which was basically more a community-based study. But they showed that the transfusion independency rate was similar to 7-day schedule or even 10-day schedule with less side effects. So that's what's been commonly been used. We tried to look at the outcome of those patients when they stopped to respond to hypomethylating agents, and their outcome is really not good, with a median survival estimated of 15 months after hypomethylating agents failure. So my tendency nowadays is not to jump to hypomethylating agents up front unless I think that the patients have a higher risk disease or features that I think that I'm impacting the natural history of the disease. Because you do see almost like a clinically a bone marrow failure syndrome for those patients after you see them not responding to other medications or other, so we try to enroll patients on clinical trials before going to hypomethylating agents in lower risk MDS. And this is again some data that we presented last year from the MDS consortium, trying to look at a shorter duration or lower dose of the hypomethylating agents. So in higher risk MDS we use 7 days. In lower risk in practice 5 days is used. In this study we tried to use 3 days, whether azacitidine or decitabine. The bottom line, the responses were almost 60%, with almost 1/3 of the patients achieving transfusion independence. So now we have a randomized clinical trial that actually has 2 parts. One, if patients are not transfusion dependent, they are randomized to observation versus treatment to ask, does it matter really introducing earlier treatment with hypomethylating agents? The other part randomizes patients between 3 arms of 5 days azacitidine, 3 days decitabine, or 3 days azacitidine. Now, immunosuppressive therapy is probably one of the most underutilized treatments. I know Steve is a little bit skeptical about immunosuppressive therapy in MDS, but it does work in some patients. So there are really different publications and different views on who are the best patients to be treated with immunosuppressive therapy. The MD Anderson group restricts its use to patients that have hypocellular MDS or hypoplastic MDS, which is very close to aplastic anemia. In the NIH data suggests actually that age is the strongest variable for response, so patients that are young, less than 60, have the highest chance of response, and that's why it makes it a limited option, because not many of the patients with MDS are below age of 60. And many studies suggest also that if it's going to be applied, it should be applied early on in the disease course. We did a study with rabbit ATG. In aplastic anemia, there are data suggesting that equine ATG is probably better. In MDS, both have been used. In our experience, longer disease duration, presence of bone marrow fibrosis, and more than prior 2 therapies were variables associated with low response or less chance of response to ATG therapy. And this year we tried to look at the impact of somatic mutations in those patients. So in addition to the clinical variable, we sequenced almost like 49 patients that received ATG cyclosporin. So what stood out, basically, we had 9 patients that had SF3B1 mutation, and only 1 of them responded to ATG cyclosporin therapy. So it seems those patients that have SF3B1 may have less response, or it may be a negative predictor. I tried also to look at the ring sideroblast, if it correlates, and there is some correlation as well there. Now, absence of mutations in general was associated with a higher chance. And patients that had any mutation, even if they responded, it was in general a less duration of response, and they had slightly a higher chance of transformation to AML after immunosuppressive therapy. I think one of the exciting medications that are in trials and maybe would have chance to be approved for MDS are medications that target the pathway, TGF-beta pathway, signaling pathway, which had been known to be active and overactivated in MDS by upregulation of downstream proteins called SMAD2 and 3. And there are 2 drugs that can target the ligands. Those are fusion trap proteins. One is called sotatercept and one is called luspatercept. So they bind the ligands before binding the activin 2A and 2B receptor, and they promote erythropoiesis in a mechanism different a little bit from erythropoietin, mostly acting on the late stages of erythropoiesis. So we tested sotatercept in a phase 2 pick winner design fashion. We demonstrated responses in almost 45% of the patients, particularly a group of patients that were not highly transfusion dependent. Almost 60% of those patients achieved an objective response, either with a hemoglobin increase of 1.5 grams or becoming transfusion independent. The German group tested the other drug called luspatercept, and this study was mainly in patients that have refractory anemia with ring sideroblast, and again they demonstrated high response rates, almost 69% of the patients becoming transfusion independent or having hemoglobin increase. Even in patients that are heavy transfusion dependent, almost 40% of them became transfusion independent. So based on this, now there is a randomized clinical trial that started called the Medalist, that patients with refractory anemia with ring sideroblasts are randomized to placebo versus luspatercept, and this study is present here at Yale, like Amar is opening the study here as well. So moving to the higher risk, when we think of higher risk, we always think of allogeneic stem cell transplant, because those patients' outcome is typically their median survival, as I mentioned, untreated is less than a year. Even with hypomethylating agents, probably the median survival for those patients is somewhere between 15 to 20 months. So you could justify the risk of allogeneic stem cell transplant for those patients. So those are what we call the Markovian decision models that try to look at the benefit or gain of survival for patients. So if patients were lower risk, the maximum gain of survival is to transplant patients at time of progression of disease, while if patients were higher risk, the maximum gain is to transplant patients up front. However, I think that the decision really should be individualized for patients. I learned over time to sit down with the patients and discuss with them the transplant and let them decide. I typically will tell them that you probably have almost 30 to 40% chance of cure and maybe a 20% chance of mortality. And it depends on the patient age and their preference, they decide on that. So if you look at the average survival for those patients, the average survival actually almost comes the same whether they go to transplant or not. But if you look at somebody that wants to make it to 10-year survival, probably nothing other than transplant makes patients live around 10 years. So I usually ask the patient what are their goals based on their age. I think somebody who's 72, their gain of survival from transplant is different from somebody who's 50. So I learned to present this data for the patients and let them decide. I don't think it's a clear cut that every single patient should be transplanted if they are higher risk, but definitely patients that are lower risk, probably the risk of the procedure outweighs the benefit up front. And we also learned that there are certain patients that if have detectable mutations at time of transplant, they may not do as well. This is again data from Rafael Behar. We validated in our cohort and other groups as well that if there is P53 mutation detected at time of transplant, especially if the patients have complex karyotype, their median survival is probably less than 6 months. So I find it difficult to ask patients to go to transplant knowing that the gain they will get out of transplant is less than a year. Although those are like small cohorts, but I kind of discuss it with the patient. I say, you have a P53 mutation. In recent data, the suggestion that the gain of survival from transplant is less than a year. Because as you know, transplant is really an intensive procedure. There are definitely patients that benefit from it. We are pretty aggressive in pursuing it, but I struggle if I know upfront that those patients will have less than a year survival of transplant to send them to consider allogeneic stem cell transplant. Other than transplant, the standard is hypomethylating agents. This is the paper that probably established it as standard of care, where they demonstrated that patients that received azacitidine in 7-day fashion had a survival of almost 24 months compared to 15 months in what we call a conventional care regimen. So those patients either received best supportive care, low-dose RSC, or intensive chemotherapy. And this is data from Dr. Gore. I cite appropriately now, I hope. So that showed that patients that had stable disease after 4 cycles, there are probably 20% chance of them getting better by 6 cycles, and maybe around 10 to 15% chance of them getting better after 6 cycles. So what we do in practice, if patients have hematological improvement, we keep going. If they have stable disease and we have no other options, which we actually don't have other than clinical trials, we continue patients with stable disease on therapy, at least somewhere between up to 9 cycles, where there is probably benefit of stable disease in those patients. This is again looking from the consortium, validating what Dr. Gore reported, that patients that had stable disease had better overall survival, and a group of patients that had stable disease between 4 to 6 months had better outcome, especially those that achieved CR later on had much better outcome. So if there are no clinical trials and no other options, which often we don't, we end continuing those treatments. But I also look at the patient clinical scenario. If patient is heavily transfusion dependent, 2 to 3 times a week platelets, I'm not sure that those patients are really driving benefit of this treatment. While if the patient have modest transfusions once a month, I may continue the treatment. But if patients are heavily transfusion dependent, I'm not sure that we really have evidence that those patients are benefiting from treatment. I'll skip through this. This is just data looking at use of azacitidine pre and post transplant. So how to improve the outcome had been really a struggle for us, and we talk about this and discuss this because we had one milestone improvement, which is an introduction of the hypomethylating agents in MDS. And we've not been fortunate. In most of the talks, I end giving a talk after multiple myeloma, where they talk about 4 drugs approved last year with amazing results, and we've had nothing other than azacitidine. So we've been trying hard to improve the outcome, but it's not had been easy as other diseases. So there are different strategies in higher risk. One is basically selecting patients that have higher benefit. But if you have one option, I'm not sure how much selection we are doing, unless we are trying to decide on patients that we can avoid sending them to transplant and we can continue them on therapy. Improve the rate or duration of response based on adding or combination strategies, or trying to introduce new agents in this field, which is challenging because the outcome is very poor after Azanucleosides failure. So one effort had been trying to look at the somatic mutations, so patients that have a TET2 mutation in 10% or more of the size of the clone, and wild SXL1 had been reported to have almost 4-fold higher chance of response to hypomethylating agents. But again, we don't have other options. So if patients don't have this profile, we are going to still treat them with hypomethylating agents. In my mind, if we can demonstrate that this profile predict a longer duration of response, so if I can say that this profile can predict a 3-year or 4-year response to a hypomethylated agent, maybe I would say we should change the timing of transplant for those patients. But the fact that we have only one option, we are going to still use the same option, whether we know they are going to respond or not to that option. Unfortunately, the combination studies had not been as successful as we like. This is just some of the studies that had been completed recently, trying to compare azacitidine with combinations. 3 of them looked at HDAC inhibitors. I think this is led by Steve and Thomas from the ECOG group. This is the intergroup SWAG study. And none of them met the endpoint showing better survival or higher CR rates. Maybe it's the sequence, maybe it's how the combination is done. We just completed a study with a drug called birinapant that's supposed to be anti-apoptotic drug that overcomes the resistance of azacitidine. And again, unfortunately, actually the data safety monitoring stopped the study earlier because there was more mortality in the combination arm. And this is a list that I looked through clinicaltrial.gov of combination studies that are going with azacitidine. You could see the theme of trying to look at the PD-1, PD-L1 antibodies, hedgehog pathway drugs, inhibitors, but there are a list of medications that are being tested in combination with azacitidine, hoping to improve the outcome. Now, the outcome, again, after failure is very poor. This is, again, paper from Thomas here that looked at the outcome. We also had the same data looking at the survival for those patients estimated between 4 to 6 months after azacitidine failure in the higher risk. And the best outcome for those patients, actually, either if they can go to transplant or if they pursue investigational therapy. Intensive chemotherapy, the response rate to those patients with a standard 3+7 is somewhere between probably 20 to 30%, with a median duration of response is 9 months. We are working on another project now, again, with the group here, trying to look at the outcome of those patients if they had MDS, azacitidine, and progress to get induction chemotherapy, what's the outcome for those patients. But it's really dismal, and probably the best outcomes for those patients is by enrolling them on clinical trials. And again, this is a list of some of the studies. Rigosertib is the only drug that had a phase 3 trial trying to look at patients that had AZA failure in the higher risk, and the phase 3 did not meet the primary endpoint. We tried to test several drugs. Erlotinib is one example. We tried single agent dasatinib. None of those trials as single agent had really translated to an outcome that could be moved to a phase 3 trial even in that setting. One thing we are excited about is trying to target those patients that have P53 mutation. There is a drug called APR-246 that actually modulates and restores the function of the P53. We had Thomas Clouzot from the French group visiting Moffitt for a year, and he did some preclinical work trying to look at the AZA-resistant cell line and the AZA-sensitive cell lines, and looked at the best timing and synergism between those two agents. And I think the best way of sequencing those would be probably, they are not synergistic, so they have some additive effect. So the way we are designing the study, they will have the APR first, and then they will have the azacitidine. We proposed this through the consortium, so this is going to be for patients that have P53 mutation, either MDS or AML. They will get the P53 modulator first and then azacitidine. So we are hoping that this will address a unmet need in this group of patients that have P53 mutation. The other thing that we are trying to look at, this is data from the public data from the TCGA, looking at patients that have complex karyotype and P53 mutation, and you can see that there is actually overexpression of CTLA4 and PD-L1 in this group compared to others. So maybe that could be also a strategy rather than treating all MDS patients with those combinations with PD-L1 or PD-1 inhibitor, to try to focus on patients that have P53 mutation or complex karyotype. I speak so fast, but I tried to go through a lot just to provide a kind of overview. So I think we've learned so much about the biology of the disease. Identification of somatic gene mutations in the 5 years, I think, have changed the way we think of the field, aiding us in diagnosis, risk assessment, and maybe provide hopefully new therapeutic options. There are some of those mutations that are targetable. I didn't have the chance to talk about, for example, there are medications targeting IDH1, IDH2. There are now spliceosome mutation inhibitors that are going to be moving in clinical trials. There is no doubt that we've tried to refine the risk stratification models as much as we can. There are some promising results with lower dose hypomethylating agents. I didn't have time to show use of eltrombopag in lower risk MDS for patients with thrombocytopenia. Luspatercept or sotatercept may be drugs to be approved in MDS. In the higher risk, allogeneic stem cell transplant remains the only curative option for those patients, and single agent hypomethylating agents are still the standard therapy. Patients with P53 mutation are probably best to be enrolled in clinical trial, and we need a collaborative effort to try to improve the outcome in patients with higher risk. That really remains an unmet need. I'll stop here. Those are all the collaborators at Moffitt, the MDS team. We get funding from the MDS Clinical Consortium and the Evans P Foundation. So thank you very much for listening. I finished in 45 minutes, Amr.